Hello, you there? Are you okay? Are you okay? If getting lost in the wet lab is also your worst nightmare, then follow me. I'm gonna show you how these bad boys and new technology, especially 3D printing, can really take your all-on-X game to another level and make it actually fun again, all right? So follow me. Sound check, 1, 2, lights, camera rolling, and action. Guys, my name is Dr. Sausha Toghranegar, and I am so honored to be able to speak to you guys today, but man, did I really want to be there in person. But you guys are really far away, like really far away. And I asked if I could show up as a hologram. Apparently that's too expensive. So are robots with my face on it. That's also too expensive. Apparently they have to pay for your guys' food. Fair. But with the power of technology and my passion for entertainment, I think we can come together and make excellent lecture for you guys today and teach you guys something about all-on-X, at least the current state of clinical all-on-X procedures. And it's been a journey for me. It's been a heck of a journey for me. And you know where every journey starts? At the beginning. So I want you guys to come on a journey with me. I want you. I want you to come with me. You come with me too. I want you guys all to come on a journey with me. You guys ready? We're gonna go back in time. So we are back in time. Probably around like 2013, 14. I'm in periodontal residency. I'm going to the library to study for a classic literature exam. And through the corner of my eye, even though I was super focused, through the corner of my eye, I see this machine, probably the size of a desktop computer, making a hand. And it would look like a Captain America hand or like an Iron Man hand. 3D printer. And it is making, for the occupational therapists, they're making prosthetic hands for kids who are born without hands. And I was like, man, that is cool. But at the time I couldn't really think of like a problem that I wanted to solve that needed that 3D printer, but I knew it was a cool device that I eventually wanted to learn how to use. Which takes us to a little bit further in the future. Here comes the problem that I could solve with the 3D printer. I'm in clinical practice at this point. So I'm like in the part of residency where we're seeing patients, and you always need to show your professor the case before you do it. Like for example, a sinus lift. You need to show your professor and describe the case on the cone beam. Problem was, the whole department, the whole like pros, ortho, oral surgery, endo, the whole school, faculty practice had one cone beam machine with one computer to view it on. So if you're trying to show your professor and all of a sudden an endo person comes over and says, hey, we need it for our patient who's screaming in pain, and you get kicked out of the room, you have to wait till next week to find your professor and sit in front of this computer and go over the case. And I mean, sometimes cases would be pushed out so far, and then it clicked. I said, what if I could take that 3-dimensional image of the cone beam in the computer and bring it in my hand? Actually get the physical model of the bone in my hand and show it to my professor. And I thought, that's a problem that the 3D printer could help me solve. So I went down the rabbit hole to figure out how could I actually print that object. And that process taught me so much about 3D printing, the technology. Like I will tell you, the concept of additive 3D printing, and don't get me wrong, in dentistry we have been doing subtractive printing using milling techniques for a very long time. Lost wax technique is kind of a way of 3D printing, but additive printing, which means you take an object, you take material, and use it to build an object up, and was affordable. Because historically, those were not affordable, and you couldn't just put them on your desktop. They were huge objects, manufacturers had them, but now you could put it in your room, put it in the office. So it's an accessible technology. With these resin-based printers, we're able to use a lot of different materials and be able to print at much higher resolutions. I mean, light curing resin is very familiar to dentists, so it ends up becoming the predominant way we make things with 3D printers in dentistry. I got so familiar with that technology that I wanted to use it for everything I possibly could. So I wanted to really make implant surgical guides. Now, heart to heart, I will tell you, making implant surgical guides was not really a popular thing to do at the time. That I am making these, what to them look like toys to use in surgery. I remember I had one professor that was like a cowboy, and he would let me really try new technology and new concepts. So we pushed forward and used different softwares to create surgical guides that were being made in the 3D printer. And I will tell you, it allowed me to excel my implant game so much. And then the biggest propelling component of it was when I got out of residency and I got into the real world. And no one trusted me because I looked too young. But then I would have the conversation of technology. Talk so fluidly about 3D printing, intraoral scans, cone beams. I would talk so confidently about the ability to bring all this technology into a software, exercise that in the actual surgery using an object that I printed, that it would seem crazy to them that anyone wouldn't do it on a past implant surgery or a future implant surgery. I was their only guy. I was the guy who could apply all the newest technology to get the most ideal results. But it allowed me again to use it frequently, and I was making my own in-house. So I got so much better at utilizing that tool. So using implant surgical guides, I advanced my implant career to a point where I feel confident doing full arch implant therapy or all on X therapy. And I'm about to show you kind of how I used to do it, or my old school method. I mean, some people still do it this way. And that's why I'm showing you via this older style Zoom lecture. But basically, I'll tell you, the surgery is, yes, it's intricate. I don't want to downplay that. But the beauty of the all on X therapy is that you can put implants at unique angles to dodge sinuses, try to get more primary stability and native bone. You can play with the positioning of your implants, so it does make the surgical side of things a little bit easier, and you can correct the angulation with multi-unit abutments that go on top of these implants that can change your access holes and make them more ideal. The real fun really comes when you start talking about the prosthetics that go on top of these multi-unit abutments. And so I do use implant surgical guides to a certain extent on these cases to kind of put me in a roughly good place. And then I'll put my implants in. If I get enough stability, I'll put my multi-unit abutments on. And then I put temporary cylinders. I used to put temporary cylinders on the multi-unit abutments and use an immediate denture, hollow out some holes for the cylinders, and lute it together with some pink acrylic. And then I would go through a very laborious process, a very messy, dusty process, making these temporaries. And remember, again, I was a periodontist, so I did not love this process. It was not the cleanest process for me, nor did I feel confident that I was doing the best job making the most stable prosthetic or temporary prosthetic for these patients. But again, if everything did heal okay in about 3 to 4 months, we would then take things off. If everything healed good, we would need a verified model, which we would then take compression copings, tie floss around them, lute GC pattern resin or some kind of resin composite to lute them together to get a good verified cast. Hope nothing shifted between us and sending it to a lab, and then go through so many different visits with the patient and sending boxes back and forth to the lab to do wax teeth try-ins to eventually, hopefully, get to a well-fitting prosthesis that the patient likes. But I will tell you, if something didn't work, we would then have to revisit 2 or 3 steps in the process, and would really drag on the amount of visits and time it would take to get to the final prosthetic for these patients. And again, that's everything if everything's going well. If the temporaries were to break, which they would do occasionally, they were not the easiest things to fix because they were kind of 2 different materials luted to a temporary cylinder. So you're just gluing it back together every time, hoping that they don't come back the very following week. And it's very important that those temporary prostheses hold together because they're splinting all the implants together. When a break does happen, you start to overload implants and can then have biologic problems, as you see right over here, there, that could cause implant failure. And again, all those steps that you would have to do to verify your impression, super critical steps. Again, so many annoying lab steps, but ill-fitting prosthetics seems to be a big problem with these full arch implant therapies. And I will tell you, I see catastrophic problems from ill-fitting prosthetic issues that then result in biologic complications and this whole process falling apart. So, I mean, again, as a guy coming from such a heavy digital background, I've been doing all these cool technology techniques and skills to improve my dentistry. And I get to the pinnacle and I'm having to do all these analog steps. Something wasn't adding up for me. I needed a better way. I mean, it always came back to the 3D printer. I mean, you know, it saved my butt in residency. It made my life easier when I got out of dental school. So maybe it'd be my hero again when it came to these all-on-X procedures that, again, I loved, but were a brain suck. You know, they really took a lot out of me. And that's when I started digging and found out about something called photogrammetry. And photogrammetry was basically this unique way of getting the exact implant positions, the multi-unit abutment positions, relative to each other. It was essentially a digital way of getting a verified impression. And you could do this at the time of surgery. So you could get a verified model at the time of surgery, and it's relatively easy. It would utilize this external camera that you would put these like domino looking structures, or they have very different versions of it at the time. You would put these flags on these multi-unit abutments, and this external camera would then capture those flags, normally within about 5 to 10 seconds. So it's a quick scan, not capturing soft tissue, but just the heads of the multi-unit abutments and the exact angulations of them. So you'd still have to get some kind of intraoral scan of the soft tissue. But if you could merge those two together and then give them some kind of idea of where the teeth were or need to be, create some kind of VDO capture for them, and there's ways to do that, and often just taking an intraoral scan before you take everything out often gets the trick done, but you send that information all digitally. There's no impression. You send it all to a lab, and a lab technician can then, this is all through email or through a portal online, can then design a set of teeth and send an STL file, which is something that the 3D printers can print, back to you. Then I found out there were resins designed for these full arch situations that were good for intraoral use for up to a year. I could use these essentially ceramic filled resins to give a patient a temporary, typically within 2 to 3 hours after doing the surgery. Once I found out that that was possible, I knew I had to do it. So I started to go the route, so I got the technology, I got the photogrammetry system, and I remember I did my first procedures and got these amazing results and never had to take a denture and convert it. I would finish the surgery, take my scans, send it to a technician, back comes the teeth, the file for the teeth, I would print it, and then give the patient their teeth that screws in with special screws directly to the multi-unit abutments. Once I found out I could do that, changed the whole game for me. Now, we had built this whole business model, this whole company of doing these all-on-X procedures for low costs by utilizing technology and to improve our efficiency. We built it around that, and I promised our patients and the doctors that work with us that that is the direction we would continue to go. Now here comes AI, a whole new technology that I wanted to implement and bring in to, again, improve efficiency, bring costs down. And while I'm looking for different tools, I come across DentBird. DentBird, just like us, is like a market disruptor. This online tool, free for everyone to use essentially, very low cost to actually kind of take out the STL files or get the crown designs from. Again, accessible, easy access, and lots of data is pouring into it because of that. So the AI that's running behind it is improving fast. And not only that, I mean, I'm keeping my eye on their company, and then they back a lab called AOX, all on X. AOX is now this opportunity for me to directly inject potential AI designing and just a company that supports the concept of AI into full arch workflow, denture workflow, which is everything we're doing in our company in Florida. And so all this technology I've ever brought with me, this company kind of merges with my thought process perfectly. And so they become the lab that we utilize to work our digital workflow. And they get it. They fully understand the system. I threw out the idea of photogrammetry, grammetry, IO Connect. They understood it all. And the communication is very seamless. I mean, everything's from an email or a portal. And so they're able to, and because they're utilizing the most efficient tools possible, and they will continue to do that too, because I know that's what's backing Dentbird and AOX is trying to improve efficiency, utilizing technology, utilizing AI. They can handle as we grow. And not only are they handling more numbers, they're also improving efficiency. The more data we feed them, the better they get. That's what you want. You don't want someone to get inundated with a bunch of cases and all of a sudden get worse. This is the exact opposite. They can handle everything and at a high level. So they were really able to help our business continue to grow, our patient outcomes to continue to grow, and make our doctors' lives so much easier. And I think now is actually a great time for us to show you some of the cases that we've worked together so you can kind of see how the workflow actually works in our offices. So I'm going to take you through a case, and this is, I'll tell you, this is probably the most standard case. Patient comes in, failing dentition, whether it's periodontal disease, a bunch of crowns that are starting to fail, they have heavy decay, they have one or the other. You know, something's breaking down where considering utilizing the teeth to fix their situation is going to be so costly, or so many steps, or there's going to be something that pushes that patient away from doing treatment. And that's when sometimes these transitions to an implant therapy are almost sometimes more affordable for the patient and become a better option even in the short run as compared to the long run. And so this case, again, failing dentition, they had actually a full arch therapy done on the upper arch. And theirs on the upper arch was actually done in an analog fashion. So there was no photogrammetry. It was done kind of that old-fashioned way I told you. Don't get me wrong, it's still, some people still do it that way, but I consider it old-fashioned. So I told him, I was like, look, on the bottom, we're gonna do it the new digital approach. So again, what you're looking at is the pre-op scanning. So we scan his bite before we actually do the surgery. And it's nice in these scenarios because you kind of have a VDO somewhat established. You have some kind of baseline to work with. And so I'll scan everything. And this is key. When you're planning out your surgery, if you can leave one tooth or a portion of a tooth leave it in place by the end of the surgery, the lab will be able to reference back to that point and then reference the VDO based off that. So in this kind of scenario, he had a second molar that I knew I could keep even after I placed the implants, because I planned on placing 6 implants on the bottom, which would be in the first molar position at the most distal. So I left a second molar. I didn't leave 2, I just left 1. Remove the remaining teeth. Go into surgery, place 6 implants. Then place my multi-unit abutments. And then scan. Then I scan again. But with the multi-unit abutments, I put healing caps in there and I leave the molar. When I scan that, that's all the soft tissue information. Just because there's healing caps on the implant, they can't use that to kind of figure out exactly where the implant's on. They get a rough idea. At that point, you could utilize either photogrammetry, which basically you take the healing caps off, you put these little flags on the implants, and you scan with an external device, or you can use OptiSplints, which again, you put these scan bodies, these special scan bodies on the multi-unit abutments, and then you take an intraoral scan, or you do what you use now is IO Connect scan bodies. I place them on the multi-unit abutments, and then I take an intraoral scan of just those diamond heads of the IO Connect scan bodies. That's done at the end of surgery. And then I put the healing caps back on, and then I remove that last tooth. That tooth that I left in there just to help kind of orient the scans, I remove it. If you know you're not gonna have a tooth left, that's when you leave markers. So before you actually get going with the surgery, after you've numbed the patient, you can put a screw or they look like little mini implants, little fixation markers into the jawbone, either in the retromolar pad area, in the genial tubercle, mid-palate. These are just different regions you can put it, but you want to put it in a place where you're not going to touch it the whole surgery. I often like to leave a tooth if possible, as opposed to doing the fixation markers, just because if you bump into them, they no longer become useful anymore if you accidentally move them in the surgery. Because there's supposed to be a reference point that takes you from beginning to end, and it's trackable so that they know how to line things up from where it started. And sometimes in periodontal disease patients that like every tooth is grade 3 mobile, you almost need a fixation marker, or they just don't have enough teeth for you to kind of save, then you need a fixation point. So this one I was able to leave a molar, and I send that information to the lab. At that point, again, I like to send my patients home so that they can rest and bring them back the next day. That gives me some flexibility to play with the design. The lab can kind of kick back a design within an hour or two, as long as I pre-notify AOX. So I send them the scans, and again, it's an email send, so the pre-op scans, intraoral scans, the soft tissue after the surgery scans, and the IO-Connect scans. So that's essentially 3 main scans. I can also send a picture of them smiling if I wanted to as well, and a profile picture as well. Those are information that can be helpful for them for the fine-tuning process. I send that information via an email, an STL file comes back to me, or a web view file where I can look at the design before printing it. But I take a look, often see if there's anything dramatic. Normally I tell them what kind of implant I placed, what kind of multi-unit abutment I placed, and then I tell them what kind of screws I am using to fixate the teeth. And a lot of times I actually use Rosen screws. There's a lot of different types. There's something called vortex screws, Powerball screws. There's so many different screws that are designed to anchor in these teeth. And I tell them exactly what diameter screws I'm using. AOX is familiar with almost all the screws on the market and almost all the scan bodies on the market. And if they don't know it, they will go out and find it for you. They then design it so that those screws will fit in there. So once I have the STL file, I then 3D print it utilizing some kind of resin that's got ceramic filler in it. The printer normally takes about 30, 40 minutes to print it, but then it needs to be post-processed. So when they come out of the 3D printer, they're a little gooey. You put them in a wash unit that washes it with alcohol. Then you check your access holes. You need to make sure those holes are super clean and clear, and then you cure it. Curing it actually gives it its final hardness, basically. And then you can paint some pink on the gingiva if it's an FP2 or FP3 type of full arch prosthesis. That means if it has gingiva in it anywhere. Sometimes they don't in FP1 cases, but this case did. So you paint on a pink, and I'll tell you, with the temporary prosthetics, it's not super critical. You nail it. I always tell them this is your healing teeth. We will work on the finals towards the end. The patient comes back the next day, normally around lunchtime. That way we've had plenty of time to be able to get the teeth ready without rushing it, really. If there's a print issue, or we have time to print another one, or figure out if we need to ask a local lab with a printer to print it for us, we often are able to troubleshoot within that time frame. We then deliver the teeth, again using the Rosen screws. We screw them into place. After we've removed their healing caps on their multi-unit abutments, we place it very gently, just making sure we're putting a little light pressure against the gingiva. And I like that because that ends up creating this nice healed keratinized gingiva, like almost like a trough of gingiva forms underneath it. Really like the way those heal. Then I tell them, I kind of give them a really good post-op instruction on how to take care of them. And I tell them if it breaks, it gets loose, you're not sure if it breaks or gets loose, you call me right away. One of the beauties of utilizing this whole process is I have your file on a folder on my desktop, not a box of stuff. If you call me saying it's broken or has gotten loose, I can print another one so fast. Next day or the same day, I'll be able to give you new sets of teeth. Now, I can also tweak the designs relatively easily as well. So if I deliver it and I know, hey, there is a little bit of issue with the bite or a lot of issues with the bite, I can then adjust the bite, scan the bite, send the email files back to the lab, and they will modify it within that same day. And I can get a file back and tell the patient, hey, come back later in the day or come back the following day to get a new set of teeth. And you can modify so easily. But a lot of the modification, I wait till the 3 months or 4 months, however long you want them to heal, till they're done healing. Then I go through several try-ins at that point. Now granted, if everything's healed well, all I really need to do is take off the prosthetic, scan the soft tissue changes. If I haven't changed the multi-unit abutment positions, I've already got my verified digital impression. I just need to show the lab how the soft tissue has changed so they can modify the intaglio of the prosthetic. Or if there's any occlusal changes or any positioning of the changes of the teeth, I can send all that information through intraoral scans and photos to the lab for them to modify the design. And again, we're not sending boxes, we're sending emails back and forth, and they can easily and quickly send me designs back that we can even see ahead of time before we print to try in. Once we've done the final try-in, that I'm like, this is the one, we then ask the lab to make it in zirconia. Or if there's a metal bar that needs to be added inside, depending on where the positioning of the implants, I will tell you it's rare. Most often, we're able to just go zirconia direct to the multi-unit abutments. And we, again, use those same screws to fixate the prosthetic in. And for as far as the follow-up, for example, on this specific case, I'm following up the patient at least 2 to 3 times every year, of which we're cleaning everything. And I try, if I can, if I've gotten the access holes in a good position, I actually will just put a temporary filling in there, something that I can pop out relatively easily and quickly tighten the screws or remove if I needed to wash everything underneath, and then change out some of the screws as a part of their cleaning process. At least once a year, if not every other year, I am doing that. I am removing that prosthetic. And I have follow-ups on this case that you could see year in and year out how the lower is actually, how tissue friendly it is. Now this last case, it's unique because I've got nothing. The patient doesn't have a denture, the patient doesn't have a bite to reference, they don't have enough teeth to reference. So I've got literally nothing to work with. This is a great scenario that if you're working with a lab that knows what your goal is in therapy, a lab that's called AOX is definitely going to understand what my goal is on this fixed case, this fixed full arch implant case. So they know I need a referenced bite. So what they're going to do, and after communicating with them, they're going to send me a file for an immediate denture that I could print and use as a reference for the VDO. So basically, I won't really need any pre-op scans per se for the upper arch. What I'm going to do at the time of surgery is I'm going to have this denture, and then after the end of the surgery, I'm going to use this denture, and once I have the implants with the multi-units, I'm using it as a wash impression, and we'll scan the denture in its entirety, the intaglio and the teeth side, with it in the mouth as forming a bite. And that will reference some kind of VDO for the lab to work with and generate some type of bite that we can go off through the process. So even if you got nothing, working with a lab that knows what you're doing, what you want, will help you get some kind of device in there to help that process of developing a VDO, occlusion, all the things you might be worried about. They'll help you take care of it. And that's the key, is communication and having the right technology and having a lab that you can easily work with that understands where you're coming from and can help you get you and your patient to where they need to go. Guys, thank you for your attention today. I hope you got the point that technology is here to help you. So go out there, really consider getting an intraoral scanner if you don't have one, a 3D printer possibly, and a cone beam to really take your dentistry to the next level. But of course, the missing ingredient, the secret sauce, is make sure you get a lab that works with you and can propel you into the future. And that is AOX and DentBird coming together to really help elevate dentistry. So I want to sincerely thank you guys for your attention, and a deep, sincere thank you to AOX and DentBird for letting me share this moment with you guys. And most importantly, thank you to them for helping my offices, my doctors, and most importantly, the patients, because that's what really matters. And again, I wish I was there, kind of. Florida's really nice right now, and the sunshine is calling me. Oh, there's a gator. There's an actual gator right now. Let me see if I can. Oh, I'm gonna bring the camera in here and show you where the gator is. Come with me. Come with me. Come with me. Come. Oh, no.